Okie doke. So I just want to welcome everyone. It seems like we've got people from all over the country. And it's the start of something we've been putting together now for sort of 3 to 6 months with Cerebra, and in particular with Dr. Younes. And I'll just give you a real brief introduction and then turn it over to Magdy. Our hope is to get a group of people together from across the country with sleep expertise to sit in on a conversation about the technology that Magdy and his team have developed in a new methodology for analyzing the EEG. And Magdy has made a point with me this week earlier to say it's not that we believe this is validated in the populations that we see, but he and I have been working together on clinical cases that we have from the clinic over the past 6 months or so. And it's been very interesting for us to listen to him analyze using the ORP, our clinical cases, and then for us to sort of sit back and look at it from a clinical perspective and see if there's applications. So we're just very fortunate to have one of the country's most senior sleep researchers and a guy I've been following since the 1990s for sure, and someone I would now call a friend and a fun guy. So I'm going to turn it over to Magdy. He's going to start by explaining what the ORP is, and then we're going to just do one case today. Our hope is to do these rounds every 6 to 8 weeks and get people on board, and then maybe take cases from the people from across the country so that you can get experience and see how this applies. And we might even be able to develop some research initiatives out of this from the wisdom of Magdy and our clinical expertise as well. So Magdy, I'm going to turn it over to you, and have a lot of fun, Magdy. Enjoy.
Thank you. Thank you. Thank you, Chuck. All right. So like Chuck said, I'm going to start with the description of what ORP is, and just so you can have an idea if for people who haven't heard about it before, and also to re-emphasize what he said, that what I'm going to say, explain what's wrong with the patient, is not fact, is basically my interpretation based on what I know, but it needs to be confirmed through clinical studies, whether what my pontifications are correct or not correct. So here is what started the ORP. Okay, so here are 4 different epochs, 30-second epochs, that are all scored awake because they meet the criteria of having more than 15 seconds of awake. And you can see then that that stage awake is not a uniform thing, that there are different gradations that we can see by eye, especially when people, can you see my pointer? Especially when people start having micro sleeps where you have, say, 11 seconds here of sleep and the rest of the epoch is awake, that's still scored awake. But so we can't really distinguish awake like the fourth epoch from the first epoch. They both scored awake. Now we put the ORP next to these epochs, and you'll see that 2.5 is the highest ORP you can get, and it progressively goes down to 1.7, which is about the time when people start thinking this is stage 1. So that illustrates the utility of ORP in distinguishing different levels of vigilance or wakefulness. And it is turning out to be quite a sensitive index of sleep loss or sleep deprivation. So the sleep deprived people would tend to have low ORP awake when they are awake during the sleep study, whereas the hyperarousal people, the real insomnia patients, will be up here between 2.5 and 2.25. So it does distinguish between a hyper alert person during the sleep study and the person who is generally very sleepy but still can be called awake. The next one are 5 epochs of stage 2. Again, they're all scored stage 2 because they meet the criteria. They have some spindles, but you can see the progression from the top one, which is almost awake except for a couple of spindles and some theta, deeper, deeper, deeper. By eye, we can tell that delta sleeps are beginning here, they are increasing, but they still haven't met the 20% 6-second criteria, so we're still calling them 2. So somebody can have hours of stage 2 and a good sleep efficiency, but in reality, his sleep will be mostly poor like this, or he could be very close to stage 3, but didn't manage to make the 6 seconds. So again, we put the ORP here, and we can see that it can clearly distinguish between these 5 different epochs of stage 2, from almost awake here to fairly deep sleep. Stage 3 usually starts around 0.6 and goes all the way down to 0. So this is what ORP does, is to allow us to see differences in sleep depth within certain RNK within the same RNK stages. So we can illustrate it like this: the maximum is 2.5, the minimum is 0. And just to show you how it relates to manual scoring, these are two top scorers, really top scorers, sitting down, scoring each epoch, 30-second epoch, but independent of each other. And when they saw epochs between 2.5 and 2.5, black means both of them agreed it's awake. Gray means one said awake, one said asleep. So minimal, very rarely this is called asleep. When we go into the next range, 2 to 2.5, we see we still, most of the time, the 2 scorers agree is awake. There are a few epochs that one says awake, one says asleep, and so on. So as we go down the ORP range, we see that the amount of black decreases. In other words, the percent of time the epoch is scored awake by both scorer goes down, and the percent that there is this disagreement between them increases. The gray zones increases until we get to 1, where it's in reverse. So if we are between 0 and 0.25, almost everybody will call them asleep, and the gray zone begins to increase, but still up to 1, most of the time, both scorers agree that the patient's asleep. There is some here that one says yes and no. So this is the relation with visual scoring. So we can generally break down the range into 1.7 to 2.5, which is generally called awake. Look at the black segments here and the gray, black and gray. Between 1 and 0, most of the time, I mean, this is sleep, and between 1 and 1.75, it is transitional. These epochs always have features of awake and sleep, and techs have a difficulty deciding whether it's 1 or 2, but usually they score them asleep. The range of ORP in non-REM sleep is from almost 0 to 1.75. So that and I showed you a slide where the ORP ranged from 0 to 1.7. REM sleep is usually a bit higher than non-REM sleep, but with the range again extending extending into awake levels, and we have a patient that shows that, but I don't think we'll get around to it. So what is the evidence that the ORP is a reflection of sleep depth? There are several papers now that show that ORP behaves in the way you expect it to under different circumstances. But the most compelling evidence is this, which was obtained from about 40,000 epochs, that we broke them down into 10 deciles, 0 to 0.25 and so on and so we had 8,200 epochs in this range and so on, so thousands of epochs. And we looked at the probability of an arousal or awakening developing in the next epoch, not the epoch that has the ORP measured, but the next epoch. So we find if the patient is down between 0 and 0.25, the likelihood of an awakening or arousal happening in the next epoch is less than 10%, and that probability increases linearly with ORP, which shows that the susceptibility to arousals, which is another way of saying sleep depth, is decreasing as ORP is increasing, and the R-square for the whole group was 0.98. Now remember, this study was obtained. This was actually Pat was part of this study, but it was done on a mixed sleep lab referrals patients. In other words, a lot of them had different severity of OSA. Some had PLMs, some had narcolepsy, some had nothing. So this is a mixed sleep lab. And if we look at this, then we see that at an ORP of 1, the probability of an arousal or awakening happening in the next epoch is about 31%. Now, I want to convert it into clinical terms, because if the probability of an arousal happening in the next epoch is 30%, that means 30 per 100, then it means if you multiply this by 1.2, it means the arousal index expected is 30 times 1.2, which is 60 over 50 or 120 over 100. And so that gives us 36. So now I've taken the left index, which is probability percent, converted it into arousals per hour. And so at an ORP of 1, we expect to have an arousal awakening index of 37, 38. So remember that, but this is for a mixed group of patients that have come to the sleep lab for some reason and were investigated. Now, I'm going to show you another one. This one we did is a recent study we published with Jim Walsh, showing the same thing, the lots of epochs, about the same number actually, and we broke it down into 10 points. No, 0.1. So these points are 0.1 apart in ORP. So we start here at 0.1 and we end up at 1.7 or so. Above that, there are no arousals because the patient's awake. So again, we get a perfectly linear relation with an R-square of 0.995. These are now normal people. And so I put in the 10 and 90% confidence limits. And so there is variability among people, among normal people, because obviously people have different, even if they are normal sleep-wise, they have different arousal profiles, as well as that scoring of arousals differs from technician to technician and so on. But this was the kind of range between 10% and 90%. And so if we look at an ORP of 1, we expect about 23 arousal awakening index. Remember that these people who are sleep lab customers or clients, they had 37 or 38%. So that means ORP doesn't necessarily reflect how much arousal awakenings you're going to have. It just tells you how susceptible to arousals you are. But how much arousals and awakenings you're going to get depends on your arousal profile. If you have a lot of arousals and strong arousals for the same ORP, you're going to get a higher arousal and awakening index. So if we now want to analyze patient scores, which line should we relate it to? We can measure their ORP and we can measure their arousal awakening index. Where do we put their data? Do we put it on this black line, which is normal people, or in this mixed lab? These people, the mixed lab referrals obviously don't have a normal arousal profile. They have lots of arousals. So obviously we should see what our patient is doing against this black line, which reflects what you should get at a given ORP if the arousal profile is within the normal range and, you know, given the vagaries of scoring arousals and so on. Okay, I just now want to show you, just take a couple of minutes to show you how we can interpret this. So this is the black line we obtained from healthy referrals, healthy people, and the confidence interval. So let's say we have a patient, we measured his ORP during the sleep study, it was 1.5. This patient has no OHI, you know, no OSA, but his arousal index is 38. So we put the dot here, and this immediately tells us that the high arousal and awakening index is because of his light sleep. You know, it's because of light sleep. We don't really expect anything more than that. The issue here becomes, that would be the next step from finding out where the dot is whether the 1.5 or the high odds ratio product is because of a central problem in regulation of sleep depth, or is it because something is causing the arousals, and because he has frequent arousals, his ORP cannot go down to very low levels. I hope that went through. So there are two possibilities for the high ORP. One is that the brain just takes its sweet time to make sleep depth progress from full wakefulness to deep sleep. This is a problem in control of sleep in the brain. The other one is that there is an arousal stimulus that causes frequent arousals, which then interferes with makes it difficult for ORP to go down because they keep interrupted. But this at least tells us one of these are the two possibilities. And to distinguish between them, whether it's a central problem or due to some arousal, frequent arousals due to something that is interfering with progression, we have the next index, which is ORP9. A high ORP9, if the ORP9 is close to 1.5 or higher, it means this is not because of arousal stimuli. It's that there's a central problem, and the reason the arousal awakening index is high is because of this central problem. The sleep is light and therefore is susceptible to arousals. On the other hand, if the ORP9 is low, in other words, the progression is fast, then we have to really look for another reason for this high arousal index. We look at another patient. Here is another patient with an AHI of 60 and also a high arousal index. His ORP was 1.4. Again, he falls on the line, and that could mean that his AHI is very high because of poor central control of sleep, or because he's got a lot of interruptions because of the OSA that prevents him from getting into deeper sleep. Now, these are pretty straightforward. Now, let's look at this point. This patient had an ORP of 0.5, at which time we should expect an arousal index of 13, 14, maximum 19. He's got 49, and he also has OSA. So it is reasonable to say that this patient, the extra arousal stimuli are coming from the OSA. But it is possible that there is something else that's going on, and we can look at that when we start looking in detail. Finally, you can have a patient like this. These are the extremes, and it's just a template to learn how to think about this plot. AHI 0, PLM 0, very high arousal awakening index. His ORP is 1. We should expect, arousal index near 25, 30. So here we have to say that the high arousal index in this patient, there is something that is causing the arousal that is not OSA or PLMs. And that is very important to realize, because in the PSG, we only look for OSA and PLMs, but the body is full of sources of arousal stimuli. The patient could have colics, the patient could have joint pain or muscle pain or itching or whatever. All of these could be arousal stimuli that would cause the arousal index to be high despite a reasonably normal one. I hope, I don't think we have time for questions now, but I hope that message went through. Okay, we are almost ready to go to the patients. What is ORP9? ORP9 is basically a description of how fast sleep deepens following an awakening or an arousal. So in the top panel, I have a patient that had an arousal here. The scale is in seconds. So 0 is the point at which visually or digitally the arousal ended. Let's start with the lower one. The lower one, again, has an intense arousal that ended around here. And you can see that during the arousal, the ORP was quite high. These dots are ORP every 3 seconds because that's how ORP is measured. We can average the values within 30 seconds, or we can leave them as 3 seconds. But we can measure dynamically the progression of sleep every 3 seconds. So you can see that when the arousal ended, this is 3 seconds later, 6 seconds later, 9 seconds later. It dropped to almost 0 within 9 seconds. So that fellow has, and we take the average of these 3 points, which turns out to be 0.65. So this patient has a very, very rapid progression of sleep following an arousal. On the other hand, this patient with the same arousal sort of intensity, this is another patient altogether. Again, during the arousal, he is pretty close to the top. And when the arousal stopped, we can see that he didn't do what this fellow did. He just went to 1.2 and then sort of meandered there. And the average of these 3 points was 1.5, not 1.51. So this is how it is measured. And if we get an average of all the arousals in these 2 patients, you're going to find that arousals has a fast component, which comes down to some kind of a plateau around 9 seconds. And so these are and then after that, there is a slow progression. In other words, if there are no arousals for several minutes, 5 or 10 minutes, this ORP is going to come down to very close to this other patient, but it's going to take it a long time to get there without arousals. And given that these patients, are sitting in very light sleep for some time, it's not likely at all that they are going to spend 5-10 minutes without any arousal. I mean, the problem with a high ORP9 is exactly what you see, is that when this patient gets an arousal, he very quickly afterwards comes down to deep sleep and becomes pretty resistant to arousals. In other words, it takes very, very strong arousals to wake this patient up. Whereas this one hangs around a very, very, very light sleep, if sleep at all, just a transitional stage, so that any slight arousal stimulus can wake him up again. And then the cycle starts again, and then you get recurrent events like OSA. So this is the big problem with ORP, with a high ORP9, is that after an arousal, you become vulnerable for a long time to another arousal. And if there are events that happen right after the arousal, like OSA, you are very likely to wake up again and you repeat the cycle. So it's not like people with high ORP9 can go to deep sleep, but they have to stay without arousals for a long time, which is difficult for them. So this is just to show you the difference between these schematically: high ORP9 and then slow progression to deep sleep, low ORP9, and then it also keeps going down, but in a very deep sleep range. And people like that, like this patient X, this is, let's say, these are the arousal stimuli in the patient. So arousal stimuli are coming from everywhere, and they can be of different intensity and different duration and so on. So I've just random arousal. Some of them are strong, 22, 20, 19. These are all arbitrary numbers. But ORP is 1.2 means it needs an arousal stimulus of 12. This is all arbitrary. If it's very high ORP, it needs a very small stimulus. And the height of each of these columns is the strength of the stimulus. So if the patient's profile of arousals is like this, the patient who has an ORP of 1.2 will get an arousal here because the stimulus is bigger than what is needed, and will go back again and again and again. Whereas if the ORP9 is only this arousal stimulus, the biggest, 28, will wake him up, but then he will go back again to deep sleep very quickly, and the average ORP will be much, much lower than this patient. So this is how ORP9 works. Okay, let's now go to our patient. The first, Chuck sent me 3 patients. I could spend several hours on each one, but I started with the first one because she illustrates a number of things that ORP can help with. 50-year-old presenting with history of frequent nocturnal awakenings and maintenance insomnia. So by definition, she has insomnia. Hopefully, someone established that she gets it more than 3 times a week and stuff like that. She also complains of snorting, which is suggestive of upper airway problems, and has the daytime complaints of non-restorative sleep and fatigue, which could be related to this, but could be related to anything. I mean, these are not very specific. Neck circumference was not bad. I don't know what LPCP is. BMI, she's not heavy at all. So these are fine. The medical history, she is postmenopausal. She has hypothyroidism, and I assume she's being treated. And she has eczema. Okay, so let's go from here and say, okay, well, there is enough. She has a lot of symptoms, and she has enough complaints to warrant a polysomnography. So she had a polysomnography, and before I get into ORP, I want to show you the conventional scoring of this lady's polysomnography, and then we will go and see what conclusions we can make from it, and then move on to the ORP and see whether we can do better. So here is her conventional sleep architecture. It's a lot of numbers, but I highlighted what's relevant. Sleep efficiency is a little bit low, 77%. What is impressive here is total number of awakenings. These are full awakenings. It's 58. That's about 10 or 11 per hour, which is huge. Awake time is consistent with the sleep efficiency. She had quite a bit of REM sleep. Arousal awakening index is 36, which obviously is very high. Sorry, and then the respiratory arousals. Our scoring, this is the automatic scoring of Michelle Sleep Scoring, called most of these arousals spontaneous, and only 11 being related to respiratory, and very few for PLMs. And again, the PLM index here. Is anybody following that? Okay. Yeah. Okay. So next we go to the respiratory stuff, and there are some hypopneas and hardly any apneas, but the apnea-hypopnea index is 10.7, mostly in non-REM sleep. And as far as body position, she spent about half the time supine and half the time in the right. She only spent a couple of minutes on the left side. So we compare supine and right. The supine is more than the right, but I mean, it's not that she doesn't have much in the right. So there is a positional element here, but not particularly impressive. And these are the oxygen statistics. She had 3 per hour, less than 4, and 7 per hour, less than 3. So not very impressive oxygen statistics. So what are we going to say from here? She has mild OSA and she has insomnia, and that puts her immediately in the category of COMISA, which is comorbid insomnia and sleep apnea. So what do we do with this patient? I mean, when you have a combination of insomnia and OSA, the conventional wisdom is that the OSA may be the cause of insomnia because it's fragmenting the sleep and so on. So the tendency is for people to go straight to CPAP and see whether CPAP helps. And what happens in this lady is, of course, what conventionally what one would do, which is put her on CPAP. And of course, I mean, not of course, it didn't work. Okay, so she went somewhere else. Here, the PSEC, this is another thing. Whoever scored this manually scored an awful lot of RERAs, which increased the RDI and made it even more reason to put her on CPAP. But she was not responsive to APAP and went through BSMS, whatever that is, and was prescribed trazodone. So this is what we have from the conventional scoring. I mean, I don't know what to say after that, but we are stuck there. That's all. Whether trazodone is going to work, I don't know. But so now we go to the ORP values. We'll see whether we can do any better than that. First of all, I'll go over the summary. Her ORP awake is normal. Now, normal doesn't have to be normal, okay? Because this is perfectly normal for someone who is not very sleepy, but also not wide awake. But she has the two disorders that cancel each other out. One is the insomnia, which tends to give you a very high ORP when awake, and OSA, which tends to give you high sleep propensity and the low ORP. So we found that people with that combination end up having a normal. So a normal wake ORP can mean it's really normal, or it can mean a combination of something that makes you more awake and something that makes you more sleepy. The non-REM ORP was 0.88, which is slightly above average, nothing to write home about, but again, that could be because of a combination of insomnia, which gives you high ORP during non-REM sleep, and sleep apnea, which may or may not. But the surprising finding here is extremely high REM ORP. So for her age and gender, the normal value is 1.16 with a standard deviation of 0.31. So she is more than two standard deviations away from what is normal for her age and gender. That is, I will talk a little bit for a few minutes about that in a minute. The other thing is ORP9 is 1.38, which is high. The average for normal people, for average for the population, Sleep Heart Health Study is 1.08 with a standard deviation of 0.21, which means that she's more than one standard deviation from normal for her age and gender. So she has these two problems with ORP that we discovered that we didn't know before. And again, I remind you of the difference between high ORP and now I want to get rid of this and get rid of this. Okay, now we get into the real stuff. So before we have the ORP, how do I get this? Okay, before we have the ORP, we can just look at what the polysomnography showed us. There's the hypnogram here, the oxygen saturation, and we can easily tell that there is not much desaturation. And we can see that the obstructive events, which are down at the bottom here, are particularly frequent in this region here, along with the arousals. But she has some other periods where she has a lot of arousals that don't have any OSA with them. So one can easily say, okay, she has OSA. more severe in one part of the night, but the other times she has RERAs or something that we don't score, and that is what is causing. And we would just write her off as just a mild OSA. We need to put her on CPAP. Now we're going to get the ORP. This is the time course of 3-second ORP. And what we can see here clearly are the conventional sleep cycles. This is the first cycle. ORP comes down, 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 and then goes up again. She was awake for a while. And then the second one goes down. And here it just can't go down anymore, so, and here again. So we can see that the ORP reflects the different sleep cycles. And look at this one here, for example. Here is this point, non-REM 2 started. ORP was still quite high. And they kept going down and down. We reached, I'm going to get the horizontal lines. So here she reached about 0.5 ORP, which is very deep sleep, and she is still in stage 2. So that shows you how the wide range that ORP can be in while the patient is in stage 2. The other thing we need to notice here is that the rate at which this second cycle went is different from this first cycle went. Here you can see that it's quite jagged, and it didn't reach 0.5 until 30 minutes after the onset of stage 2, whereas here it reached it in less than 15 minutes. So there is a difference in the rate at which sleep progresses, depending on how many arousals there are. So that shows you that when you have lots of arousals, it delays the progression. But that doesn't happen in people who have very low ORP9, because already they are way down, and even if they get an arousal, they will go back right away to deep sleep. And so they're already at very low level. So the only people who oscillate like this with lots of arousals and take them a long time to come down are people with high ORP9, which we already established they have. This one had very little arousals, and you can see despite the high ORP9, she managed to go down much faster. But there are people who go down much faster than even this second cycle who have a very low ORP9. But when she had OSA, clear OSA, she just hardly ever managed to get, but she still did manage. What the key point here, which is very, very important clinically, I think, is I have that horizontal line at 0.5, and you can see that every time she went below 0.5, she stopped having OSA or even arousals. Even during this period of OSA, when she managed to sneak in and get down below 0.5, she stopped having OSA and have very few arousals. So that 0.5 threshold is not a universal threshold. This is her threshold. In other words, if she is above 0.5, she's going to cycle. If she's below 0.5, she's not going to cycle. So her OSA is ORP dependent, which gives us a handle on another way that could possibly treat this patient, is that by lowering her ORP using one way or the other, we can actually treat her OSA. Hopefully, I mean, this is again, remember, these are all pontifications based on seeing lots and lots and lots of people, but no follow-up. I don't have outcomes, so we need to pick patients like that and see whether this pans out. That when we find a drug that can lower the ORP faster, their OSA will disappear. But this is a very important observation in that her OSA is ORP dependent and sleep depth dependent. So if we can manage to get her sleep depth better, she will not have much in the way of OSA. And the second thing is that her ORP9 is not high enough that it's preventing her from reaching that threshold. That she does manage to reach it, in some cases, even here when she had, what happened at this point, when she was coming down, she missed the hypopnea here. Okay, so she missed the hypopnea and missed the I don't have time to show you it. It's really very nice. She missed the hypopnea, and so she had more time to drop her ORP to below 0.5. And once she got that, she became quite stable. But then something woke her up, which is not really an OSA. It was a spontaneous awakening. So I need to check my notes here to see. So
Magdy, we have one question for Magdy.
Yeah.
We have one question from Manisha Whitmans, and she's just reflecting on what you've just said. Clinically speculate, how would you reduce the ORP? I mean, we know because it's our patient, we know what we did, but give your opinion.
No, I'll come to that about the management of this patient. I'll have time to do it. I'm going, what time is it? Okay, fine. So our next, we can stop here with this ORP data and say, well, okay, she has ORP, she has OSA, bad here, but probably she has these other arousals that occur without OSA are still because of upper airway problems and that are waking her up, but they don't meet the hypopnea criteria. So our next, if we know that her ORP9 is high, we need to check these arousals that are happening outside and awakenings. You see here she was coming down very nicely, but woke up. Here she was coming down, and every time she comes out, something wakes her up. So we need to check this section here and see whether these oscillations are because of respiratory events like RERAs, or because they are due to something else. So I'll take you here. When I showed that to other people, they get quite taken by it.
This is pretty cool.
Okay, so this is a window we have in our scoring system that gives us the ORP in EEG1, EEG2, and the average for every 30-second epoch. So this one here is pretty close to awake, and it's scored awake. I'm just going to move quickly. Actually, it was even higher than that before. 2.4, 2.4, 2.4, 2.3, coming down a little bit. Maybe we can see some sleep here. 2.3 again. Here is 2.25. Again, we're beginning to see some periods of sleep. 2.1, a bit more sleep. This is showing you how sensitive the ORP during stage awake is to these mini sleep. Now she's 1.8, and it's pretty close to, I mean, there's a lot of sleep here, but also a lot of beta activity. So it's close. This is a transitional state now, and we keep moving. 1.6. See here now she is in solid stage 2. Now spindles and nice sleep, and she's down now to 0.68, which is around here. Sorry, she's around here. Keep going. 0.7, 0.55, and now she starts going up again, and then she gets this big awakening. So what we want to do, we want to troubleshoot these awakenings and see whether they are respiratory or not. So I'm going to do this trick. I'm going to go back 3 epochs and then change the compression to be 4 epochs per view. So 1, 2, 3. So we are now 4 epochs from the awakening, and we're going to put it at 120, which is, boy, this thing is annoying. So, okay. So this is nasal flow. And so we are now looking 4 epochs before the awakening, and there are, what looks like, before she woke up, she started getting these disruptions, which are like many arousals that didn't make it to be an arousal. And let's look at breathing here. Does anybody see anything that's worth calling? Look at her thermistor. Look at her thorax and abdomen. There is no paradox. Nothing has changed. The saturation is pretty flat. The heart rate is pretty flat until she woke up, and then it started going up. So there is nothing here to indicate that this is respiratory related awakening. Okay, I did the same thing for these attempts, 3 or 4 attempts at going to sleep that all get interrupted by awakening, and none of them was what they were all like this. So now we try to look at the arousals here. What is causing these arousals? So here is an arousal, here's an arousal, here's an arousal. So this is a period of frequent arousals, and again we look at the breathing and the thermistor and the saturation and the pulse and all. There's nothing to say there is any. So, but some people will call these RERAs, because they find maybe there is a couple of breaths that have flow limitation, and so they call it. But RERA, remember, and this is very important. RERA, the abbreviation is for respiratory effort related arousal. So that means it is an increase in effort that leads to arousal. An increase in effort under sleep is always related to changes in blood gases. So we don't have any changes in blood gases here, but we don't have anything to say respiratory. And for respiratory effort related arousal, when they open up, when they have an arousal, they open up and they're supposed to get an increase in ventilation. So that the fact that her flow rate here is the same as before during the arousals indicates that her effort before the arousal was not high. Therefore, this is not a respiratory effort related arousal. Okay, so we established then here that these excessive arousals in the absence of respiratory are not related to OSA. And whereas if we go through here, this section, which has a lot of OSA, we're going to find that every arousal is related to a previous hypopnea. So now we established that the OSA is doing something for sure to her sleep, but it's only limited to 1.5 hours here. Outside this 1.5 hours, the OSA is not responsible for her arousals, but the high arousal awakening index is, there must be other causes. So now we end this by going back to, I'm going to skip that. Going back to this framework, and so we put the dot right where it is. Her ORP was 0.88 and her arousal index was 36. So we put it here. So we see that she is on the edge of the normal values, but also, I mean, this is quite high arousal. We can't really just send her off as normal. We have identified that she has insomnia. She has high ORP9, and this is the next is the last slide. Is to say, well, okay, is that increase in arousal awakening index relative to her ORP? Is that all because of the OSA? So now I did something for the first time, but it's really very nice, So I'm going to break her sleep because we saw differences in the sleep cycles. I'm going to determine this relation between ORP and arousal awakening index in the 5 sleep cycles. So we'll do this. So we have the 5 sleep cycles, 1, 2, 3, 4, 5. I'm going to determine the ORP, average ORP in each of the 5, and the arousal awakening index in each of the 5. And here we are. Okay, so number one is this one. So you can see even without OSA, her arousals are higher than her ORP. Number two is this one. We can see that it's still higher than what is expected. It's on the edge. 4 and 5 are these ones. So 1, 2, 4, and 5 are all sitting around the edge. That means that she's either a way out normal person, which she isn't because she has symptoms, or she has something else other than the OSA that is causing the excessive arousals in the background of high ORP9. Number 3 is this one where we have the OSA, and you see now it's higher than all the others, relatively higher than all the others. So if we fix number 3 by putting her on CPAP, she's just going to drop to an arousal awakening index of 40, which is not really treating her. So, but this tells us that the patient has something other than OSA that in a background of high ORP9 will give her a lot of arousals. So our job then as physicians, this is what I would do if I found this in a patient, is to say, okay, I'm going to go back to be a Med 2 student, and I'm going to do a proper systems review and bring her in the office and ask her about every organ system in the body, see if any of them can be a source of arousals. In her case, the eczema might be a source, but it could be her GI tract, or it could be her bones, or whatever. So that would be the first thing to do in this patient, is to see if there are other sources of arousals that we can deal with. She may be hyperthyroid. I mean, I don't know, but we really need to look not just at OSA and PLMs. We need to, because there is definite evidence here that something else is bothering her sleep. I wouldn't bother with anything to treat OSA, but the focus then should be on how to lower her ORP. Now, the best way to lower her ORP is to lower her ORP9. And I looked at so many of the commercial systems, but they don't give us their effect on spectral power. So I can't really tell whether we have any drugs that can lower ORP9. But I know that CBT lowers ORP9. We've done studies on that. And so the next step, if I can't find something in her skin or whatever that we can fix, is to put her on CBT, particularly the sleep restriction component of the CBTI, and she will probably get better, and their OSA may disappear. If the CBTI doesn't work or she doesn't tolerate it, and of course CBTI has to be titrated properly so we don't over-restrict her sleep, then the next step will be drugs. And drugs, trazodone is as good as anything, but I'm not sure that it actually lowers ORP. One thing to know about hypnotic drugs is that different people respond differently to different hypnotics. And so what works in one person might not work in another, and vice versa. So that we should not, if one drug doesn't, until we find a drug that clearly lowers ORP9, just like sleep restriction, we just have to do therapeutic trials with different drugs. And maybe we can even do it with home ORP to see whether, rather than waiting for 6 weeks to see whether it works or not, is to have the patient do ORP every time they change the drug at home. And if we find one that lowers ORP9, then that is the holy grail of sleep medicine. I think, again, remember this is quantification from an old.
Magdy?
Yeah, I'm finished. This is it.
Let's just take one question from your colleague, Pat. He's asking, can you comment on the ORP during REM in this patient? It is consistently high in the absence of respiratory events. And following the answer to that question, of course, everyone can head on, and we'll stay in touch.
Okay, well, I told you that what we find is very, very high ORP. And so, if ORP is a measure of sleep depth in REM, then it means that people are very susceptible to waking up with any stimulus, and then have bad dreams or whatever. And so I worked with a friend of mine, Diego Mazzotti in Kansas now, to do the relation between REM ORP and REM sleep fragmentation. So, and here are the results. Okay, I'm just going to remove this. So this is from the 5,700 patients, subjects in REM, some of in sleep heart, some of them have OSA, some don't, mostly normal, half of them are normal. But look at the range of ORP9, of REM ORP in this 5,000 patients. I mean, it goes from 0.6 to 2. Look how many of them are more than 2. You know, her REM ORP is about 2.2. Hardly anybody is there. So she is really, really, I mean, standards. So high REM ORP predisposes to REM fragmentation. And here are two papers. I'm going to give you this presentation so you can get these. These two papers say that REM fragmentation is very common, is a high risk factor for depression, as well as a high risk factor for nightmares in PTSD. And therefore, it is possible, that's another handle on this lady, it is possible that her high REM ORP, which is extremely rare to be that high, is causing her, is associated with depression, and the depression is partly responsible for her fatigue. And so all these, I don't know of anything that can lower REM ORP. But again, you know, this opens the question of, let's look for something that lowers ORP9. I think sleep restriction lowers ORP a little bit, but not very much. That's all I have to say about REM ORP. So what happened to this patient?
That was just perfect.